Uh, a very good evening to all of you, my dear friends. And I am Dr. Piyush Gupta, Professor and Head Department of Pediatrics at University College of Medical Sciences, Delhi, and also the President for Indian Academy of Pediatrics for the next year, that is 2021. Why I am here and what's my relation with Professor Sisir Kumar Bose? It's a legacy because Dr. Bose started the first the Journal of Indian Academy of Pediatrics, that is the Indian Pediatrics. The journal is now more than 50 years old. It is into its 57th edition, and I started, or rather, I matured my journey of with Indian Academy of Pediatrics as a 10th editor of this journal, for which Sisirda was the first editor. So, and in the 1900, in 2013, we celebrated 50 years of Indian pediatrics, and it was my fortune that I gave the oration in the name of Dr. Bose sir in the Pedicon National Golden Jubilee celebrations at Kolkata only, and where the his family was also present, and I was blessed by them at this particular function. So, Sisirda, I am always indebted to you. And as a previous recipient of this oration, I have a very fond memories of that oration. And I would have loved to be present in Kolkata, definitely more for the hospitality and food and everything. I love you like anything. So I am very happy to inaugurate this session today, the Sisir Kumar Bose Memorial Oration, in the memory of Dr. Sisir Bose. I think everybody knows him, so there is no need to further elaborate upon it. And I'm happy that Professor Mahesh Goenka will be talking on the evolution of pediatric gastroenterology. And we have Professor Sugato Bose, none other than him, who just returned from Harvard. As he said, he's just completing his home quarantine today. So that is an appropriate moment to give his opening remarks. And I request Dr. Sugato Bose to now give his opening remarks. I formally inaugurate the session open. Thank you.
Thank you, Dr. Piyush Gupta, for inaugurating the session. Uh, my younger brother, Shumantra, and I are delighted to join this occasion. And we are very grateful to Dr. Apurva Ghosh, Director of the Institute of Child Health, and all his colleagues for organizing this event, and to Dr. Mahesh Goenka for accepting their invitation to deliver the Dr. Sisir Kumar Bose Memorial Oration in the centenary year of our father's birth. 2020 has been a difficult and challenging year for humanity and also for our family. We lost our mother, Professor Krishna Bose, on 22nd February this year. She was a founding trustee of the Institute of Child Health. Dr. Sisir Kumar Bose was a multifaceted personality. As a young medical student, he was called upon by his uncle, Netaji Subhash Chandra Bose, to play a very important role in our freedom struggle. His uncle called him to his side and asked him, "Amar ekta kaj korte parbe? Can you do some work for me?" And this was in December of 1940. And from that moment onwards, Shishir never stopped doing Netaji's work. To begin with, he drove his uncle in his Wanderer car from his Elgin Road home in Calcutta to the Gomo railway junction in January of 1941. That was not just the first leg of the escape, but it was the first step in the transformation of Subhash Chandra Bose to Netaji. There would not have been an Azad Hind Fauj if that escape had not succeeded. Now, Shishir spent many years in British prisons in the Red Fort, the Lahore Fort, and Lalpur jail. When he was released in September 1945, his father, Sharat Chandra Bose, told him that all the slogans that he was hearing about the Bose family, especially Bose Khandan Zindabad, was nothing but the reflected glory of Netaji. So he asked Shishir to go back to his medical studies, which he did in medical college. He then did his DCH from the Great Ormond Street Hospital in London. He also trained in Sheffield and Vienna in the late 1940s. Somewhat later, after his marriage, and when I was barely 2 years old, he went as a Rockefeller Fellow to the Harvard Medical School. And in 1958, 1959, he trained in pediatric radiology at the renowned Children's Hospital in Boston. And he worked with a wizard in that field called Dr. Ed Newhouser. And I'm very happy that there is another specialization that I'm hearing about today, pediatric gastroenterology. That will be the subject of today's oration. My father was, as has just been pointed out, an institution builder. He wrote the Constitution of the Indian Academy of Pediatrics, was the first editor of Indian Pediatrics, and he wrote something very interesting in one of his earliest editorials. To us in India, as in all countries in development, pediatrics is more a mission than a means of livelihood. So for him, pediatrics was of course a profession, but it was also a form of public service. And during his centenary year, we have received so many messages from his colleagues, his students, his patients. There are parents of children whom he had taken care of who have preserved all his prescriptions. He didn't prescribe very many medicines. He would prepare meal charts for the children whom he treated. And so he was, apart from everything else, an institution builder, and he has left as his legacy 2 very fine institutions in this city of Calcutta. The first, of course, is Netaji Research Bureau, which he founded in 1957, and which is a world-renowned institute of history, politics, and international relations. He has preserved for future generations the best traditions of India's freedom struggle. And the other institution to which he devoted many decades of his life as director, and then in his final years as president of the Institute of Child Health Trust, was, of course, the Institute of Child Health. So here was a life dedicated to the children of India, to the future of India. And I'm so glad that today's pediatricians have chosen to remember him. And I, along with my brother Shumantro, join the rest of the audience virtually in looking forward to listening to Dr. Mahesh Goenka deliver the Dr. Shishir Kumar Bose Memorial Oration. Thank you very much.
Yeah.
Sir, unmute yourself. Dr. Gupta, you're not audible.
Yeah, thank you, Professor Bose, for those remarks and letting us know the history and legacy of Sisir. Now, I request Professor Apurva Ghosh to carry forward the session further, introduce the speaker, and go on with the oration.
Yeah. Dr. Mahesh Goenka is one of the best gastroenterologists. He actually started the pediatric gastroenterology in West Bengal, and he is very renowned, and he trained in PGI Chandigarh. But before we go forward, I will request Somnath, can you show the video for the...
Yes, sir.
Oh, yeah. So we can start now, Dr. Goenka. You will have to unmute yourself, Dr. Goenka. Dr. Goenka, oh yeah.
So can I have my first slide? Good evening, everybody. Am I audible?
Yes.
Professor Piyush Gupta, Professor Sugata Bose, Dr. Sumantra Bose, Professor Apurva Ghosh, and my friend, Professor Tapanjyoti Banerjee. It's indeed a great pleasure to be here among all of you and to deliver this prestigious oration. I'm really humbled by this gesture of Institute of Child Health and by its director, Dr. Apurva Ghosh. I'm also so happy to see Professor Sugata Bose here. He doesn't know, and I was sharing this with him, that I am an unknown fan of his. I know him as a great educationist and a big orator. I've heard some of his speeches in the parliament and was really impressed by that. So I'm so happy that both Dr. Sugata Bose and Dr. Sumantra Bose are here for this oration. I know you heard Professor Bose talk about multifaceted personality of Dr. Sisir Bose, and I may be repetitive, but I think some of the people have joined later, and I would like to highlight some of the aspects of the multifaceted personality of Dr. Sisir Bose. He was a patriotic and participated in the freedom fight. He was a great politico-social activist. And for us doctors, most important that he was pediatrician par excellence. As you heard Professor Bose talk about, he contributed a great deal in what ultimately became a big freedom fight of Azad Hind Fort by driving Netaji in this car from Calcutta to Gomo to Delhi and onwards. And he participated in the Quit India movement. And as mentioned, he was a prisoner in various prisons, including Red Fort and Lahore jail. As a politico-social activist, he created this wonderful institute in Elgin Road, Netaji Research Bureau in 1957, and has authored more than 40 books and titles on Netaji and was representing West Bengal as a member of West Bengal Legislative Assembly in early days. But as mentioned, for us doctors, he was one of the best pediatricians of his time. He had his initial training in India, but subsequently, as mentioned, went to London and subsequently to Harvard as well. And he started this journal, Indian Pediatrics. This is 1964 to 1966, when he actually formulated the journal and took it forwards for almost 3 years. And you all heard that he started this institute with Dr. Chaudhary, Institute of Child Health. We are all Calcuttans are very proud of this institute. And I had the opportunity to visit this institute a couple of times. It's a wonderful institute for child clinical services, and subsequently was the president of this thing. And I think I chose the same line as Professor Bose did, that in his first editorial, he wrote, and I think this still is so relevant today, when he said, and Professor Bose, you just heard him quoting this line, to us in India, as in all countries in the developing world, pediatrics is more a mission than a means of livelihood. I think indirectly, pediatricians formulate the future of any developing country. And I think this line, though it was written in 1964 by Professor Bose, still holds true. So what I have chosen for this next 40 minutes is to talk to you about the specialty of pediatric gastroenterology. Let me first tell you that I am not a hardcore pediatric gastroenterologist. I do practice pediatric gastroenterology more by compulsion, because in the initial days in Calcutta, there were hardly any pediatric gastroenterologists. I was trained partly in pediatric gastroenterology during my DM days in PGI Chandigarh, and have been practicing pediatric gastroenterology, but I am not a hardcore pediatric gastroenterologist. But I've seen the evolution of pediatric gastroenterology from the very beginning. And just like Dr. Sisir Bose was a pediatric radiology passionate, I think pediatric gastroenterology is another very important specialty. So if you look at the history of pediatric gastroenterology, and Dr. Piyush Gupta is here, Dr. Ghosh is here, you'd all agree that this is how it started. In 1968, the first society was formed in Europe, which is popularly known as ESPGHAN. And this was the society which subsequently led to similar societies being formed in North America, Latin America, Commonwealth, and then an Asian Pacific, Pan-Pacific in 1993. It was as late as 2000 when the first World Congress of Pediatric Gastroenterology was organized in Boston, and which was called Federation of International Study for Pediatric Gastroenterology and Nutrition. So this is only 20 years. So relatively, it's a young branch. Now, let me now focus on the pediatric gastroenterology development in India. And I had the opportunity to work with Dr. Saroj Mehta for good 13 years while I was in PGI Chandigarh doing my MD, DM, and then working as assistant and associate professor. So I saw how the pediatric gastroenterology developed with Dr. Saroj Gupta at Chandigarh, Dr. S.K. Mittal in New Delhi, and Dr. Sankar Narayanan in Chennai. And they were one to start the seeds of pediatric gastroenterology. And it was as late as 1984 when the first time in Indian Academy of Pediatrics, a pediatric gastroenterology chapter was added. I remember those days. She was so happy that at least some beginning has taken place. And the Indian Society of Pediatric Gastroenterology, Hepatology, and Nutrition is yet not even 10 years old. It's only in September 2013 that this society was formulated on the same line as European and American societies. Now, how is the training of pediatric gastroenterology taking place? And again, this is a story which is worth remembering. These were the three institutes, PGI Chandigarh, where I worked, Madras Medical College, and SGPGI Lucknow, who did not have pediatric gastroenterology program, but the pediatrician took the initial step of allowing the MD pediatrics to join the DM program. So they would join the adult DM program and will participate just like the adult gastroenterologists would do and get a DM degree, which will be called DM gastroenterology. But this attempt failed miserably. And I would say why it failed miserably, because those pediatricians who were trained for this 2 or 3 years course found it easier to practice adult gastroenterology because they were trained somehow for about 2.5 years in adult gastroenterology rather than practice pediatric gastroenterology. So they are spread all over the country, but they are mostly practicing adult gastroenterology. And that was not the purpose for which this was started. So true pediatric gastroenterology practice training started in 2002 with a PDCC course of 2 years at SGPGI Lucknow. This was the first training which was exclusively pediatric gastroenterology training. And it took 10 years at the same institute to start DM in pediatric gastroenterology. So the first institute to start DM in pediatric gastroenterology was SGPGI Lucknow. And 2 years later, it was DM hepatology, which was started in ILBS Delhi. And then we had DNB course, which was called FNB, started in Apollo, Delhi. And finally, in 2015, the second institute started pediatric gastroenterology. And this is my alma mater, PGI Chandigarh. So the first product came out in 2017-18 from PGI Chandigarh. Now, I'm also, before I get into the academics, must talk about these two colleagues of mine with whom I had the opportunity to share my hostel rooms, Dr. Yacha, who recently retired as the head of pediatric gastroenterology from SGPGI Lucknow. I had the opportunity to share a common room with him during my DM gastroenterology days, and Dr. Anil Dhawan, who is now at King's College London heading the liver transplant program, who was 6 months junior to me in PGI Chandigarh. Both of them have contributed a great deal to pediatric gastroenterology. And before I proceed, I'm very happy that two of the most prominent pediatric gastroenterologists of the city I had the opportunity to work with. Dr. Bhashwati Acharya did her DNB program with us at Apollo Clinicals Hospital. And Dr. Subhamoy Das, who is the first DM pediatric gastroenterologist from PGI Chandigarh, is now working with me at Apollo Clinicals Hospital. So now let me move on to the pediatric gastroenterology. In 30 to 40 minutes, you can neither cover, though, give an overview of the subject as wide as pediatric gastroenterology. So what I'm going to do is that give you a glimpse of the three components: hepatology, luminal pediatric gastroenterology, and endoscopy. Endoscopy is my passion. And so I'll spend more time talking about pediatric gastroenterology endoscopy. So let me just touch upon hepatology and luminal thing. I think one aspect which I think I must touch upon today during this lecture is liver transplantation. And if you look at this figure, this is only updated till 2016. In Apollo group had performed 2,608 transplant. Mostly they were life-related transplant. A very small percent were cadaver transplant. And of these, 210, almost around 8 to 9%, were in children. And the major indications for doing transplant in children were biliary atresia, Wilson's disease, PFIC, acute liver failure, chronic liver disease because of hepatitis B and C, and autoimmune hepatitis. And the results had been very, very satisfying. In fact, we have also done a couple of cases of children in Calcutta. And I would like to share this child whom we transplanted last year, 6 months old child with biliary atresia. And this is day 3 after transplant. It was a very sick child. And this is a picture almost about a year back of this child who has grown up. And I had the opportunity to meet the family just a month back. And they are so happy that this child could be saved. So this is a success story of liver transplantation at Kolkata Apollo. I'd also like to share another success story from the Apollo group of a child from South India. This is a small child, again with biliary atresia. You see, this is after success from the Chief Minister of Andhra Pradesh is felicitating. This is young child. He is driving a mobike. He's grown bigger. Now see, he's a young man. He had fractured his left arm, but he's still smiling. Now he's become tall. He is on the Week magazine. And finally, recently last month, he graduated as a doctor. So this is a story of a success of liver transplantation from biliary atresia, which is such a bad disease, to now he's a doctor and is doing great job. I must say that pediatric liver transplant is one of the most challenging surgery. And this requires a teamwork, as in most of the specialties, we require that a surgeon has to join hand with a pediatric gastroenterologist, a pediatric intensivist, and a paramedical staff. Our story of biliary atresia was one such example. And I remember how Dr. Subhamoy Das worked very hard along with pediatric intensivist and the surgeon to make that child survive. Now, let me now move from hepatology to luminal thing. And there's only one disease I'll talk about here, which has a great importance. This is celiac disease. We know all that this is wheat allergy, the gluten sensitivity, which causes celiac disease. And the story started from London. In Central Middlesex Hospital, the first intestinal biopsy of child was done who had celiac disease. And this was published in none other than Lancet Journal in 1957. And from there, we evolved these various stages of celiac disease, so-called Marsh histological staging. Why I have picked up only one disease so far as luminal is concerned, because celiac disease has taught many things to us. One, this is a disease which is primarily a GI disease, a gastroenterology disease, but is seen by almost all specialties because the manifestation is so widespread. And second, this is one disease where pediatric gastroenterologists have trained adult gastroenterologists. When it was pediatric gastroenterologists who invented this disease, understood this disease, and then we now know that a significant proportion of patients presents in adulthood for the first time. So it is a pediatric gastroenterologist who have taught the adult gastroenterologist about this disease. Now, there's been a lot of myth about celiac disease. In 1960s, when this disease was invented, it was considered that it's a very rare disease. But this myth was found to be false in 1960s itself. Then it was thought that this disease happens only in some part of Europe and not in rest of the Europe. That was again proven false in 1980s because of the epidemiological studies. Then it was thought that this is a disease only seen in Europe and not in other countries. But in America, then we had a huge number of cases diagnosed. That was in 2000. And then we thought that this is a disease which happens only in the Western countries. But I'll show you some of the data that in last 10 years, we have realized that this disease is very much there in India. And now there are reports of this being present in the rest of the Asian countries also. So this is a disease which have evolved in the epidemiology from a very rare disease to now not so rare a disease. So this is a study which was published in 2018 in Clinical Gastroenterology and Hepatology from Delhi. And they evaluated the prevalence of disease in various countries from 57 studies involving more than 1 lakh individuals. And they found that 0.68%, that means 1 in 140 individuals, suffer from celiac disease. So if you go to the Western world, you will find in most of the malls, there are shops which sell products which are gluten-free. Unfortunately, at this moment in India, the such products are rarely available. And so we have very difficult situation treating these individuals. Now, then there were 3 studies which were published from India from 2006. This is a study from my colleague from PGI Chandigarh, who is now in Ludhiana, Dr. Ajit Sood. Then Dr. Maharia, again a product of PGI Chandigarh from 2010 from Delhi. And then my colleague, Dr. Kocher, whom I shared the office space in for many, many years in PGI Chandigarh. So these 3 studies showed that this disease does exist in India. It's not a disease which is not seen in India, though the prevalence may vary in different parts of the country. So this is a map which was created for celiac disease in India. You see it's predominantly in the northern India, in UP, Punjab, in Rajasthan, and so on. But this study from All India Institute of Medical Sciences showed us that if you look for the disease is there. So in 1999, there was only 1 case diagnosed in the whole year. And as the period went on, the number of cases diagnosed increased to more than 154 in 2011. So it is that you have to look for this disease to diagnose the disease. And sometimes looking for the disease is not so easy because the presentation can be variable. Now, we initially thought by that map that the disease is only in the northern part of India, but subsequently they have been studied from southern part. And more important for us, there's a study from northeastern part of India, which has shown that the prevalence is almost as much as that in North India. So this is a study from Guwahati, which has shown that the prevalence of celiac disease is 0.87%. That means almost 1 in 100 individuals have celiac disease. And we know how important it is to diagnose celiac disease because the whole natural history, whole the dynamics, demeanor of the patient will change if you can diagnose and treat it properly. And this is the point I was trying to talk about, that though celiac disease is a disease of pediatric gastroenterologists, and 55% of them will present with diarrhea, but almost half of the population will not present with diarrhea as the main feature, but they may present as anemia, short stature, and so on. So this is a disease which should be, one should suspect this disease not only as a pediatric gastroenterologist, but for any specialty. In fact, this is what it can be. So this can present to a hematologist as anemia. It can present to a neurologist as cerebral ataxia, epilepsy, and neuropathy. It can present to a dermatologist as alopecia, dermatitis herpetiformis. It can present to a gynecologist as amenorrhea and infertility, to an oncologist with a complication of lymphoma, to an endocrinologist because of pubertal delay and short stature, and of course to a gastroenterologist with weight loss and diarrhea. So I think this is a disease which we should make all specialists understand, whether they are pediatrician or adults, whether they are neurologists, oncologists, gynecologists, gastroenterologists, or endocrinologists. And now we have good tests to diagnose celiac disease. You have antigliadin IgG, antigliadin IgA, endomysial antibody, and anti-TTG IgA with a very good sensitivity and specificity. You can diagnose celiac disease. And then, of course, you have endoscopic features, grooving, scalloping, mosaic pattern, and decreased fold height and number, which can make you suspect this disease when you do an endoscopy. And biopsy, as I showed in one of the earlier slides, can be very, very diagnostic. And stopping gluten can change this person. This is a guy from Hyderabad. You see before gluten with the diagnosis of celiac disease, and just after 4 months of giving therapy, which is gluten-free diet, you see the child has started improving. So I think this is a disease which every pediatrician, whether you are a gastroenterology practice or non-gastroenterology practice, every adult, whichever specialty you are, you should understand. And gradually, as we recognize this disease, we are seeing more and more cases. Now, I'll now move from hepatology and luminal pediatric gastroenterology to endoscopy, which, as I said, is my passion. I spent about 50% of my work time as an endoscopist. So when endoscopy started, this was 1940. Look at how the endoscopy is being done. He is the endoscopist who is sitting on the floor. The patient is on the table, head is outside the table. This nurse is holding the head with her finger inside the mouth so that the patient doesn't bite the endoscope. This was how endoscopy was performed in 1940. So any day if this sister is absent, the endoscopy will be canceled because you cannot do the endoscopy without an expert nurse. Of course, this doctor, he was very smart. He married the sister so that she cannot take any further leaves. Now we are lucky that in 2020, we have very advanced endoscopy. This is video endoscope, which has made life so easy for us, not only for performing the procedures in a good way, but also for training and research. And the result is that you have such nice endoscopic picture. This is a polyp, and you can see the head of the polyp with microscopic characterization at the time of endoscopy. So we are fortunate that we are now practicing pediatric gastrointestinal endoscopy in 2020, where our life is much easier. Now I'll divide the indication of endoscopy into those which are for upper GI, those which are for lower GI, for small bowel enteroscopy, ERCP, and maybe we'll talk a little bit about EUS. Upper GI endoscopy is indicated in these situations: dyspepsia or abdominal pain, reflux, dysphagia, that means difficulty in swallowing, unexplained vomiting, malabsorption syndrome, foreign body ingestion, upper GI bleed, and sometimes to perform endoscopic gastrostomy. I would like to highlight one point here, that just because you have a hammer, you don't start putting nails everywhere. You must choose the indications very clearly. And this is a point which Dr. Ghosh also told me a couple of days back. Then we must be very clear as to which individuals requires these procedures. Any person coming with abdominal pain of any child coming with abdominal pain of 5 days or 7 days, you should not rush into doing an endoscopy. There are definite indications. So if somebody is having a prolonged abdominal pain or have warning signs in the form of weight loss, vomiting, GI bleed, anemia, these are the individuals who should be subjected to endoscopy. Otherwise, most of the time endoscopy, if you perform unnecessarily, will be negative. And we should understand that these are not totally non-invasive procedures. Now, when you do an upper GI endoscopy in various indications I talked about, you may get these pictures. This is esophagitis. You can see ulcers here. This is an ulcer. This is hairball. This is trichobezoar. Often happens in psychological individuals. We see it rarely, but we do see them once in 6 months to 9 months. There is a child who swallows either his own hair or sometimes parents' hair, can have this ball of hair inside the body. Then this is a polyp. This is a celiac disease with scalloping of the fold. And this is a hookworm. You can see blood inside the lumen of the hookworm, and this can cause anemia. Now, we still in our country have tuberculosis as a very common disease, and this is a patient with esophageal tuberculosis, which can have either polypoidal lesion, and you can see that caseous material coming out through this, or they can be ulcers. And if you take a biopsy, you may find granulomas in these patients, and then you can do a PCR to confirm the diagnosis. Now, in my time when I was doing my MD and DM days, we were told that the ulcer disease is uncommon in childhood. It is no more so. I think now we know that even in childhood, you can get ulcers like this. This is a duodenal ulcer. And with this Warren and Marshall inventing Helicobacter pylori, and you all know that they got Nobel Prize because of this invention. You now know that duodenal ulcer and peptic ulcers can be caused by Helicobacter pylori. So you can not only look at the ulcer, but you can take a biopsy and subject it to various tests to diagnose presence of Helicobacter pylori. And let me tell you, in childhood, now in the last 10 to 15 years, gastroduodenal ulcers are not uncommon. But when you get an ulcer in a childhood, you should also think of uncommon causes, which can include Crohn's disease, tuberculosis, lymphoma, annular pancreas, mastocytosis, and sarcoidosis. So not all patients with gastroduodenal ulcer childhood are common garden variety of gastroduodenal ulcer, but you should always suspect them when you are dealing with ulcer in a childhood. I was telling you that we are fortunate that we have now huge magnification possible. So look at this picture in a young boy, and you can see that this is squamous epithelium in the lower end of the esophagus, and this is columnar epithelium. So this makes the diagnosis of Barrett's esophagus almost confirmed even at endoscopy. So columnar epithelium in the middle of a squamous epithelium is a diagnosis which is suggestive of Barrett's esophagus. We have gone a step beyond, and we have in our hospital something which is known as confocal laser endomicroscopy. This is actually world's smallest microscope. So you pass this probe with a microscope attached to the tip of it through the normal endoscope, and then you get pictures which almost looks like histology. So this was a child who had Peutz-Jeghers syndrome, and he had multiple polypi and he was losing weight. So we did a confocal endoscopy microscopy on this. While some of the areas show this intestinal villi, you can see the villi, you can see the blood vessels. Mind you, this is not histology. This is endoscopy. So at endoscopy, you can see the villi, and we could see while most of the areas had normal villi, as you can see them, some of the areas has this distorted architecture, which suggested that there was malignancy coming in. So we did biopsies in this patient, and we found that this patient though it was a Peutz-Jeghers syndrome, had developed malignancy, and that was responsible for weight loss. So this technology is very promising and can help us in getting magnified picture and to get a histology in vivo. Now let me change the gear and move to upper GI bleed in children. Now these are some of the pictures of common causes. This is varices, this is an ulcer, this is an AV malformation. And these are the various causes of upper GI bleed in children: variceal bleed, erosive gastritis, peptic ulcer disease, stress ulcers, Dulophois lesions, vascular malformation, and sometimes tumors, tuberculosis, and Crohn's disease. So we did some study, and this is a study which we published, that we look at all population, adult as well as children, varix were more common than ulcers. And these are some of the other causes. But in children, somewhat ulcers were more common than varix. So though they are both common causes of GI bleed in children, but we found ulcers and ulcerative lesions to be more common than varix. Now, before I talk about the management of GI bleed in children, I must say that it's not all endoscopy. And one should not go to rush into doing an endoscopy in these patients. You must assess the patient. You must resuscitate by giving blood and products and other things, and must start pharmacotherapy. Depending on whether you are suspecting variceal bleed or an ulcer bleed, you can start the various agents. And it is very important that you fill the tap. You don't not allow the bleeding to take place, but you must fill the tap with fluid and blood. And then RBC transfusion must be done in hemoglobin less than 7 grams per deciliter. And then comes the role of endoscopy. I think endoscopy today plays a very, very important role, and we have been able to reduce the morbidity and mortality in these pediatric gastroenterology patients by doing endoscopy at the right time. So these are the varices, and you can see this is what is known as red color signs. And then you can apply multiple bands in this bleeding. And this is a short video in a 12 years old child of and tell you this was the esophageal varices. Gastric varix is a different ball game altogether. So these are the varices in the stomach, and these are labeled to various types. I will not go into details of this, but the gastric variceal bleeding can be massive. You can see this is a young man, 20 years old, who is bleeding massively from gastric varix in the fundus. So your treatment is entirely different. In these patients, we inject what is known as a glue. So I'm injecting a glue inside the varix, and then with this, as it comes in, the glue comes in contact with the blood, it solidifies. So you can see I've injected about 3 ml of blood, and immediately the bleeding stops. And I can press this varix with my needle and see that the varix has become now solid like a rock. So this is a different ball game. And if you manage these patients aggressively, the bleeding otherwise, which can be fatal, you can see amount of blood which was there, can be easily controlled. When we talk of non-variceal bleed, that is an ulcer bleed, we must do an endoscopy to find out what is the status of the ulcer. So we classify them as to Forrest class. This is class 1, which is a bleeding vessel. Class 2A is non-bleeding visible vessel. Class 2B is adherent clot. Class 2C is central pigmented spot. And class 3 is a ulcer with clean base. So depending on what type of ulcer you have, you decide whether you need to do an endoscopy or endotherapy or not. So for Forrest 1 and 2A, you should do endotherapy. But Forrest 2C and 3, you should not do endotherapy. For Forrest 2B, you should only do endotherapy if you have all the modalities available. So what are the modalities? They can be either injection, thermal, or mechanical means. And the initial success rate is 80 to 90%, irrespective of what therapy you use. So this is a technique which I'm very passionate about. So this is what is known as argon plasma coagulation. So through the endoscope, I'm passing this probe. This patient has Henoch's colon purpura and was bleeding from an ulcer. You could see a red central spot. And I'm coagulating the base of that spot with argon plasma coagulation. This is an 8 years old child who had Henoch's colon purpura, and this bleeding can be easily controlled. Of course, if you have a bleeding like this and this patient has stomal ulcer, which was spurting, you can use clips just like a surgeon uses clips for after cholecystectomy, that you can use clips endoscopically and stop these bleeding. Very recently, in last 5 to 7 years, a new types of clip has come into the picture. This is known as over the scope clip or Ovesco clips, which is mounted on the endoscope, just like varicose band ligators. And this is a metal clip. You can see how it's mounted. So this was a young child whom we had done a polypectomy. The child comes back to us after day 2, and we find a large amount of blood in the stomach, and we could find that the point for where I had done the polypectomy had started bleeding. So I injected some material at that particular site to make it very clear. You can see the black India ink, and then I'm releasing the Ovesco clip, and within minutes, you can see that within minutes the bleeding has been completely stopped from that polypectomy site. So, like a carpenter, you have to choose your tool very effectively when whenever you're dealing with these emergencies. Now, let me move from bleeding in the upper GI tract to the strictures. And strictures in childhood can be caused by peptic and corrosive, rarely by tuberculosis and Crohn's. And you can dilate either by using bougies or balloons. Now, this is one such child, a young child, I think 3 years old, who had presented to us with narrowing in the lower end of the esophagus. And you find at endoscopy extensive ulcerations all around with narrowing. So I passed a guide wire there, and over the guide wire, I'm dilating fluoroscopic control, and look at this picture. Just after one dilatation, that the stricture has opened up. Sometimes you may need to do more than one, and you see how easily I could pass into the stomach just after one dilatation. Now, achalasia cardia is sometimes seen in the childhood. As we all know, it's failure to open the lower esophageal sphincter. And a new technique has been started. I have done only one case, I must say, in childhood, but majority of our experience in the adult. Now, this is what is known as POEM. This is the extreme of endoscopy. Here we are doing surgery not inside the lumen, not outside the lumen, but inside the wall. So I have created a hole inside the wall by producing an incision on the mucosa. I've entered the submucosa. I'm stopping the bleeding, whatever blood vessels comes in contact, and then I pass my instrument up to the lower end of the esophagus. Mind you, it's inside the wall. And then I'm doing a myotomy, which a surgeon would otherwise do. And then after I've done a myotomy, I come out and close the mucosal incision, and that completes the procedure about 30 to 40 minutes. You all know that Heller's myotomy has been the standard of care for achalasia cardia, but the situation is changing. The POEM is gradually replacing Heller's myotomy, both for adults and childhood. Now, another very interesting aspect of the endoscopy is management of GI foreign body. And this is my collection. It's an incomplete collection from children. In the last couple of years, you see coins are the most common foreign body which is ingested, but you can also see batteries, pencils, you have hairpins, blades, safety pins. These are some of the hairpins, the key holder, the again so-called safety pins, and various types of instruments which patients swallow. In fact, in India, there is no regulations on the toys, so that sometimes the toy parts are swallowed by the children. And one must remember that 80% of these foreign bodies will pass without any problem, but 20% is likely to get stuck in these various areas which are relatively narrowed or angulated. Then foreign bodies which are long, large, sharp batteries, and those where pyloric stenosis or pyloroplasty has been done should be removed. And these are some of the instruments which are available with us to remove this foreign body. I'll just show you a few examples. This is a coin, which is the commonest. And I've become rich collecting these coins. But then you can also have sometimes foreign bodies which are interesting. This is a gold foreign body, an earring. I removed it endoscopically. I requested the patient's relatives to give it to me for my stock, but they refused. So this has gone back and it's not in the list which I've shown you. Now, marbles can easily pass, but sometimes we have to remove the foreign body because the parents are very apprehensive about it. So this is a marble which I'm trying to remove with a Roth basket. Now, some of the foreign bodies can be very difficult to remove. And look at this one on the left side and one on the right side. Now, one on the left side is a long nail, which is 5 centimeter in length with a very sharp end, and it has passed into the second part or third part of duodenum, and I'm trying to remove it. One on the right side is a half blade. You remember this is a half blade which was swallowed by a child 1 year old, you can see, and this was again removed. When you remove these foreign bodies which have sharp ends, you have to really be very cautious, because if you do not show cautious, then these sharp ends of the foreign body can lacerate the intestine, particularly the esophagus, where you are removing. So you see how carefully I'm trying to remove this nail, and you see the length of the nail is 5 centimeters. So the carpenter was working in the house, and the child swallowed this nail, which went in the third part of duodenum and was stuck there. when you are treating the foreign bodies, you have to make your own music. Sometimes we plan the thing outside as if we are removing a foreign body and decide how do we go about it. Now, this is another interesting aspect that sometimes we do percutaneous endoscopic gastrostomy. This child, 2 weeks old, presented with Pierre-Robin syndrome, had micrognathia and difficulty in swallowing, and the pediatrician referred this child to us at 2 weeks to perform a percutaneous endoscopic gastrostomy. You can see the punctured site, and we performed this gastrostomy so the nutrition of the child could be maintained. Let me now move from upper GI endoscopy to lower GI endoscopy. And the indications for doing lower GI endoscopy, colonoscopy is diarrhea, bleeding per rectum, suspected tuberculosis Crohn's, and screening from familial polyposis. Now, these are some of the pictures of lower GI endoscopy: self-limiting colitis, ulcerative colitis, polypi, and solitary rectal ulcer. Let me tell you, I practiced for 14 years in PGI and I hardly saw any solitary rectal ulcer. But in India, in Calcutta, sorry, we see a lot of solitary rectal ulcer syndromes, and these patients often have finger evacuation. I think in Calcutta, we are very, very particular about our bowel habits, and we will do everything so that the bowel movement takes place, and sometimes use finger. And we found this association of finger evacuation with this rectal ulcer formation, solitary rectal ulcer. Now, tuberculosis can often be diagnosed very easily by colonoscopy. And this is a classical picture of ileocecal tuberculosis. You see nodules, ulcerations, you can take biopsies, subject them to PCR studies, and then reach a diagnosis. Of course, Crohn's disease remains a differential diagnosis. So the features which favor Crohn's disease are sparing of the ileocecal valve, epithoid ulcers, longitudinal placement of the ulcer, cobblestoning, and pseudopolypi. So if these features are present, you should suspect Crohn's more common than tuberculosis. Coming to the intervention in the lower GI, polypectomy is the one which is the commonest. So if there is a pedunculated polyp, it is very easy to remove. And I think surgeons should not try to remove polypi. They can be so easily removed at endoscopy within minutes. Even if the polyps are sessile or they have a broad-based, uh, let me just show you the end of this polypectomy. So we have cut the polyp, and because of the current, there is coagulation. Even if there's polyps are sessile, you can put these clips which I showed you for bleeding so that the bleeding does not take place and you can remove this polyp easily. Now, let me now move to another area, which is enteroscopy. Enteroscopy means small bowel evaluation. I think till about 20 years back, small bowel, which is really not small, it's a long structure in adults, will measure as much as 20 feet, was a dark area, a black box for the endoscopist. But these two developments, formation of this, creation of this capsule endoscopy and balloon assisted enteroscopy, has allowed us to investigate the small bowel very easily. And I had the opportunity, I'm of course having a mustache at that time, to be a host for these two individuals, Paul Swain from London, who invented capsule endoscopy, and Dr. Yamamoto from Japan, who invented balloon enteroscopy. This is a Hyatt lobby where they came and they delivered lectures. So capsule endoscopy is actually a miniaturized camera, less than an inch in size, with all the components of the camera, works on radio frequency waves, and these are the other components of the system. So this is a pill cam capsule. So as soon as you swallow the capsule, it moves down and then takes picture, almost 6 to 8 pictures per second. And then you download these pictures onto a dedicated computer. And by press of a button, you can find out where the lesions are, particularly where the blood is, and then spend some time looking at these. So this is a story of a 12-year-old child who presented with fever and anemia. And I did a capsule endoscopy in this child. And I found that there was a narrowing with nodularity all around. So this patient, because of the presentation like this, which was missed on all other investigation, diagnosed in capsule, we did a surgery, removed that part of the gut, and we found a caseous lymph node along with intestinal tuberculosis. And this patient was very easily managed. Otherwise, would have been a big surgery, or we would have waited for a long, long time. Now, we published our data, both in adult and children, in various journals. Now, these are some of the pictures of capsule endoscopy. You can see this is a polyp. This is an ulcer because of NSAID. This is an ulcer because of tuberculosis. This is Crohn's disease with narrowing. This is AV malformation. This is hookworm. This is an hemangioma. And this is abnormal varix, ectopic varix. Now, ever since we have started doing capsule endoscopy, we have realized that Crohn's disease, which was considered to be uncommon, is quite common in India. And these are the features of Crohn's disease at capsule: fissuring, serpiginous ulcer, cobblestoning, aptoid ulcers, multiple ulcers, and stricture formation, which can make us diagnose Crohn's disease as capsule endoscopy. Now, this is the experience of Crohn's disease of capsule endoscopy in children. And if you look at obscure GI bleed, most of the studies have shown that majority of the patient you can diagnose by doing capsule endoscopy. Now, other type of endoscopy is balloon-assisted endoscopy. You have either two balloons. By inflating and deflating them, you can move inside the small intestine by stabilizing the gut. Or now we have single balloon endoscopes also. And it has been shown that both single balloon and double balloon endoscopy have high diagnostic yield with very low complication rate. These are some of the pictures in young children. This patient had on small bowel enteroscopy ulcers, and this patient has a submucosal tumor with an ulcer over the top of it, which had presented with GI bleed. Now you have the advantage that when you have balloon enteroscopy, you can also do surgical intervention. So this patient with Peutz-Jeghers syndrome had multiple polypi. The patient would not be ready, the relatives will not be ready for a surgery. So we removed that by small bowel endoscopy. And this patient required 12 units of transfusion before the patient came to us. We did an enteroscopy, found a bleeding AVM, and you can see by using organ plasma coagulation, I've controlled the bleeding. Mind you that in next 3 years of follow-up, the patient did not require any further blood transfusion. Now, the last leg of my talk, and I'll take about 5 more minutes, is on ERCP. I think this is another area which is very, very close to my heart. Now, this is how an ERCP picture will look like: a pancreatic duct, a bile duct, a gallbladder. But you now never do an ERCP for diagnostic purpose. For diagnostic purpose, you have either an MRCP or an EUS, endoscopic ultrasound, by which you can diagnose most of the condition. Why we do not do diagnostic ERCP? Because ERCP, all said and done, have a small but definite risk of complications like pancreatitis and bleed and perforation. So you should do only for therapeutic intent. And therapeutic intent in childhood, in pediatric area, can be either for biliary diseases or pancreatic diseases, for stones, injuries, strictures, parasite, or for acute pancreatitis for stones, chronic pancreatitis for stone, stricture, and so on. Now, this is a young child. I think it was a 5 years old child who presented with a stone in the bile duct. And you can see that I have done a sphincterotomy. I've done an ERCP, and now I'm doing a sphincterotomy by which you are cutting open the papilla, which is 1 millimeter into almost a centimeter in size. And then pass the balloon. As you can see, this is a balloon, which is almost like a Fogarty catheter, which is passed in, and under fluoroscopic control, you can see the stones in the lower part. And this is a Fogarty catheter-like balloon. And I'm now withdrawing the balloon, and you withdraw the balloon, the stones will come out. So you see one stone here, and then I pass again, and I remove a few more stones. So I think this has again changed the whole approach to the biliary disease. Otherwise, a pediatric surgeon would require a major surgery to remove these stones. And sometimes we pass a stent inside the bile duct till the cholecystectomy is done. Now, even if there's a stricture in the lower part of the bile duct, and you see there's a tight stricture in the lower part of the bile duct, and there's a stone which is there, I can dilate this stricture by means of a balloon, as you can see, and then pass what is known as mechanical lithotripter, by which I'm holding the stone there, and I crush the stone into small pieces, and then remove these pieces in the normal way. So I am crushing the stone by mechanical lithotripsy. We also have laser lithotripsy to treat these patients. And then you can see the small fragments are being removed and the stricture has been dilated. Now, another area of very interest is roundworm. You can see this is a bile duct roundworm. This is, I'm performing a cholangioscopy. This was a 13 years old child, and my cholangioscope is inside. Now we have a cholangioscope that we do not only have to depend the images. We can go inside and you can see a roundworm inside the bile duct of this young child. This is possibly the first picture in the world of a roundworm at cholangioscopy. And then I'm removing that roundworm with help of a balloon, and you will see the tail of the roundworm here. So these can cause severe problems, including cholangitis, jaundice, and so on, pancreatitis. So I'm holding the roundworm with the help of a foreign body forceps. And you can see a large roundworm, which was inside the bile duct, and this was a live roundworm. So we always give anti-parasite drugs after we have removed the roundworm, because often these worms are in multiple numbers. And once you have done a sphincterotomy, they may pass inside again. So we remove this worm, as you can see, very long one, and then you take it out. Another very interesting case I would like to share. This is the 18 years old female who had this liver abscess, two of them, and multiple times aspiration was done. We were really surprised why the abscess is coming back again and again. And we did an MRCP, and MRCP showed the bile duct to be dilated. So we went in suspecting there must be something in the something in the bile duct. And thick bile came out when we were using the Fogarty catheter balloon. And then you see what comes out. So this is a leaf-like worm which was inside the bile duct. This is what is fasciola hepatica. So this liver abscess was recurrent. This young girl used to swim in a pond somewhere in Barasat area and would develop this fasciola hepatica. And we removed, if I remember right, 3 such worms from the bile duct. And then we gave the drug niclosamide in this patient. We had to get this drug, it was not easily available. We requested Novartis to give this drug. And then we treated this young child with this therapy. So you see the worm is still alive while it's in the duodenum. And we removed, I think, 3 such worms from the bile duct. So this is fasciola hepatica. Now, pancreatitis and pancreatic disease is a different ball game altogether. Pancreatic endotherapy is a different ball game. So this is an 18 years old male who had this stone at the pancreatic opening. So all I'm doing is doing what a gynecologist and obstetrician will do, an episiotomy, and the stone delivers itself. So I just cut open the papilla, and then with the help of a basket, I'm removing the rest of the stones from the pancreatic duct. Mind you, pancreatic stones are entirely different look than the biliary stones. These are whitish stone. And then after we cleared the bile duct, you can see the bile duct opening, the pancreatic duct opening is entirely different. I'm putting a pancreatic stent inside the pancreatic duct so that to reduce the risk of post-ERCP pancreatitis, and then remove this stent after a few weeks. Now, another very interesting disease in the pediatric childhood is pancreas divisum. So this is what a normal pancreatic duct would be, a ventral duct, which will open along the bile duct. Now, sometimes the dorsal duct is predominant, and this opens in minor papilla. Now, here I'm going through the minor papilla. This is a major papilla. This is a minor papilla, which is usually proximal. So you can see this is a major papilla. This is a minor papilla. Very rare disorder, but you must diagnose this usually by MRCP and then do the ERCP. I'm cutting open the minor papilla. Mind you, the major papilla is intact here, and then pass a guide wire and put a stent, and then take care of pancreas divisum in this situation. So you can see I'm putting a stent in the minor papilla. Now, this is my last case, I think. Now, when there's a peripancreatic collection following pancreatitis, usually acute pancreatitis, this is a collection, you can see an MRI, which shows a large collection around the stomach with necrotic material inside this, which we now call as wall of necrosis. This can be managed endoscopically. So what I'm doing here is I'm creating a fistula. So this is a bulge in the stomach caused by that collection. So I'm creating a fistula and then dilating the tract with a balloon. And then once the balloon is dilated, you can see dirty fluid has started coming, but I don't stop at that. I put a stent in this, a self-expandable stent. And then after 2 days, I enter through the stent into the peripancreatic collection. And you can see the necrotic material lying there, which I'm removing. So by doing this procedure 2 or 3 times at an interval of 2 or 3 days, I cleaned up the peripancreatic collection from all the necrotic material. And I think a major surgery could have been avoided. Now, this is another very interesting case. This patient had portal biliopathy, and patient presents with GI bleed. And when I did a side wing endoscopy, I find a huge amount of bleeding taking place. So this patient, we put a metal stent inside the bile duct, and the bleeding was immediately stopped. So the moral of the story is that whenever you have bleeding from the GI tract, whether it's upper GI tract, middle GI tract, or the lower GI tract, you can have an umbrella because you have various modalities at your armamentarium so that you can control most of the bleedings. Now, my last slide, 3 slides, are a little provocative. Now, who should practice pediatric gastroenterology? I don't think it should be a gastroenterologist who should practice pediatric gastroenterology. It should be a pediatrician. And this is Dr. Sutapa Ganguly, who is a pediatrician who is predominantly practicing pediatric gastroenterology now. Why so? Because as I hinted in the beginning, in 1980s, whenever the pediatrician will get exposed to the adult GI, they will start practicing adult GI. And when you have an adult GI man, he would have plenty of work to do from the adult population. So he cannot do justice to managing the pediatric patient. So I think it should be a pediatrician who should practice pediatric gastroenterology, and he should focus on managing pediatric GI patients. But who should own the pediatric gastroenterology division? And I think this is again provocative. You need to have these setups for practicing pediatric gastroenterology. You should have endoscopes, you should have manometry, you should have breath tests, you should have fluoroscopy, you should have GI lab, and you should have training module. So if you are fortunate enough to have an independent department or division where all these modalities can be available, that's the best option. But in practice, most of the time, these facilities are available in a gastroenterology department. So a pediatric gastroenterologist can easily do a practice by being a part of the gastroenterology department. And of course, last option would be if the pediatric department can have all these, of course, that can be a good option. So I would say it should be a pediatrician who should practice pediatric gastroenterology, but he should preferably practice it in a gastroenterology department to make the matters more logistically correct. Of course, a pediatric gastroenterologist have to hold hands with a general pediatrician and a gastroenterologist or an endoscopist to carry on with very focused and productive work. I must again thank the whole team of Institute of Child Health, Professor Ghose, Professor Gupta, Piyush Gupta, Professor Sugata Bose, Dr. Sumantra Bose, and all of you, and my friend, Dr. Tapanjyoti Banerjee, whom I shared my hostel room while I was doing my MBBS in Calcutta Medical College. This is my team at Apollo Clinicals Hospital. And whatever we have done, whether in pediatric gastroenterology or adult gastroenterology, has been possible only because of teamwork. Thank you very much.
Thank you. Thank you, Dr. Goenka, for your excellent presentations and your huge experience. The first time this presentation, or similar to that, when I heard about 10 years back. So I was so impressed with that I thought that one day Professor Sisir Bose Oration will be given by Dr. Mahesh Goenka. Now I request Dr. Tapanjyoti Banerjee to conclude the session with his remarks. Tapanjyoti, you need to unmute yourself. Tapanjyoti, we cannot hear. Yeah.
Hello. Good evening, everybody. Thank you, Dr. Goenka, for your such an excellent, elaborate lecture on pediatric gastroenterology. Actually, Dr. Mahesh Goenka is my bosom friend. I was before I was asked to give the introduction of his career. Dr. Goenka actually was my classmate in medical college. He did his MBBS from medical college. And after doing the MBBS, he went to PGI Chandigarh for his MD-DM. And after DM, he was assistant professor there. And he was also associate professor in the PGI Chandigarh. And after that, he came back to Kolkata. First, he joined AMRI Dhakuria. Then he's joined the Apollo Clinicals Hospital. Now he's director of Apollo Clinicals Hospital. And both in his chief gastroenterologist there. I am proud of him because he's not at all a gastroenterologist of Kolkata at all. He is nationally famed and internationally famed. He is the fellow of American College of Gastroenterology. He is the fellow of American Society of GI Endoscopy. He's the first Indian who got this honor. And also, he published more than 200 papers in the international journal. He is the governor of American College of Gastroenterology till 2023. Recently, in the last month, he was awarded with the International Leadership Award by American College of Gastroenterology. He's the first Indian who got this honor. Practically, I am proud of my friend Mahesh Goenka. He's doing lots of work on pediatric gastroenterology in Apollo Clinicals Hospital. And he is editor-in-chief of Journal of Digestive Endoscopy. Thank you, Mahesh, for your excellent lecture. Everybody has enjoyed your lecture. And in future also, we'll hear lots of things from you. Thank you, Mahesh.
Can we request Dr. Sugato Bose or Dr. Sumantra Bose, even if it's not in the agenda?
Yeah.
Yes, of course.
Sumantra, would you like to go ahead? I sent a chat to all the panelists.
You need to unmute yourself, Dr. Bose.
Sumantra, you need to unmute yourself.
Yes. Can you hear me now?
Yes.
Well, I heard your presentation, Dr. Goenka, with absolute fascination. And my father, who left this world 20 years ago at the ripe old age of 80, would be so happy and proud that physicians of your caliber are practicing in Calcutta and are bringing their experience from all over the country and abroad to bear for the welfare of the children of India. I really mean this very sincerely, that you would be so happy and proud today. I was also thinking that an institutional legacy is so very important. And it's because Dr. K.C. Chaudhary, who happens to be our and my grand uncle on my mother's side, Krishna Bose's side. She was Krishna Chaudhary before her marriage. And it's only because some 65 or 66 years ago, Dr. K.C. Chaudhary, who was India's pioneering pediatrician, took the initiative to establish the Institute of Child Health, which was then carried forward by my father, Dr. Sisir Bose, later by Dr. Apurva Ghosh, and so many of his excellent colleagues, that we are getting to know about all this medical expertise in one place. And that's the value, that's the worth of an institutional legacy. An institution takes a long time and a lot of hard work to build, and even more to sustain. But I think all of that work is worth it at the end of the day. I'll end with a small personal anecdote. When I was just 5 years old, I suffered a rather serious freak injury in our then home, which was at 1 Woodburn Park. So when I was seeing the slides of all those children who swallowed coins and needles and everything in between, well, I hadn't swallowed anything, but I was hit with a projectile. And I remember that I was rushed, bleeding heavily, in a yellow Calcutta taxi. This was sometime in 1974, I think, to the Institute of Child Health, where I was given critical care. My mother stayed with me for the days that I was in critical care, and then I recovered fully. So I'm personally, very grateful to the Institute of Child Health for what it did for me. It was my brother knows about this. It was really a very serious injury that involved a great deal of bleeding from a 5-year-old. So on behalf of all the children who have benefited over the last many years and decades from the care of the doctors and staff of the Institute of Child Health, a hearty thank you, and please do keep up the good work. Dr. Sisir Bose is no longer here in person, And Shugoto said at the beginning of this session that we suffered a great personal tragedy in February this year when our mother suddenly left us at the age of 89. But please rest assured that Shugoto and I are here to be of whatever support we can to your endeavors as you go on in your mission of pediatrics. Thank you very much.
Thank you. Thank you, Sumant.
Let me just add my warmest thanks, my deepest gratitude to Dr. Mahesh Goenka. I just want to say that your passion for endoscopy in particular came through even to a non-specialist like me. And it was a lecture in a field which is far removed from my own, but I just listened mesmerized to you for the entire hour. And it seemed that you have made such advances in the field of endoscopy in particular that you might actually put a few pediatric surgeons out of work, because you're being able to intervene with endoscopy in so many difficult cases. And while some of it could may be invasive, it is certainly not as invasive as major surgery. So it's not just the instruments that you showed, but human ingenuity in the use of instruments of new knowledge in giving relief, particularly to children who face challenges in this field of gastroenterology at a very young age. Thank you very much, Dr. Goenka, and carry on the good work at Apollo Gleneagles, and do continue to cooperate with the Institute of Child Health. As you said, there has to be a partnership between pediatrics and gastroenterology if there's to be advance in this field. Thank you very much.
Thank you.
Thank you, Mahesh.